Baik, saya ucapkan sekali lagi terima kasih atas kehadiran kalian semua ya dalam acara guest lecture yang sebenarnya ini merupakan bagian dari kerjasama antara Fakultas Farmasi Universitas Jember dengan Fakultas Farmasi dari RCMP UniKL Kuala Lumpur. Dan kebetulan sepertinya ini bukan yang pertama ya dengan Nur Safwan. Jadi Mr. Nur Safwan ini sudah pernah berkunjung ke Fakultas Farmasi kita sebagai exchange researcher, I think. Dan kemarin saya sudah pernah juga diundang ke UniKL, so kali ini adalah giliran kita berbalas kunjungan gitu ya, terkait dengan guest lecture. So today, Mr. Safwan will discuss or share with us about clinical pharmacokinetics, especially in TDM, therapeutic drug monitoring. I think it's very important for us because one of the tasks of one of the something that we have to do in hospital usually is how to make sure the safety of the drug, especially a drug with the narrow index therapeutic, I guess. One of the example is Aminoglycosides. So Nur Safwan is one of the lecturer in the RCMP UniKL with the specialty, I guess, in pharmacokinetics. Is it right? So before Nur Safwan share with all of you guys, I want to give you a short introduction of who is Nur Safwan is.
Macam mana saya nak tutup muka saya?
Okay, this is the curriculum vitae of the Nur Safwan Hadi bin Nur Afendi. He is one of the lecturer in Department of Pharmacy with the discipline of clinical pharmacy and pharmacy practice in Faculty of Pharmacy and Health Sciences. In here, Faculty Pharmacy, in UniKL, they have Faculty of Pharmacy and Health Sciences. So he is also the secretary of UniKL Pharmacy Webinar and also secretary in Malaysian Pharmacy Society, secretary in Malaysian Pharmacy Society Education Chapter, and also the course leader in drug and substances abuses. So if you want to contact, maybe you will have a further question about this lecture, you can contact him with in his email in nursafwanhadi@unikl.edu.me. So this is his educational background. The latest background is he already in Master of Clinical Pharmacy in Faculty of Pharmacy, Universiti Kebangsaan Malaysia. And I think Mr. Nur Safwan has a lot of expertise, and one of them is the pharmacokinetics because it's one of the field in the clinical of pharmacy. So you can see the subject which he do or he teach in the university. There are pharmacotherapy and then pharmacokinetics and also hospital toxic. So, and one of them is drug and substances abuse, and so on. So, the membership until now, he is a membership of Malaysian Pharmacy Society, and then Clinical Research Center, International Testing Authority, and then Pharmacy Board of Malaysia, Anti-Doping Agency of Malaysia, and ordinary member of Malaysian Pharmacy Society. So this is the working experience of Mr. Nur Safwan. I think it's a lot of experience of him. So I think it's very interesting because in this time he will share with us or discuss with us about how to do TDM or what is TDM and what is the important about do the TDM in patient. But not in all of the drugs. So I think Mr. Nur Safwan will be discuss with us, share with us what the drug that we have to do the TDM. So not all of them. So Mr. Nur Safwan, you all ready to share your lecture?
Okay, let me share my screen first.
Okay, wait a second. Stop my share. Okay. Can you share? Okay.
Can I start the sharing session, Dr. 15?
It's already.
Can you hear my voice?
Yes,
Okay.
clear.
All right. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all participants. Thank you very much for the kind introduction, Dr. 15. And today I would like to share my experience and also knowledge on therapeutic drug monitoring (TDM). So this is more towards introduction in case study sharing of aminoglycoside. So actually, I have been invited by Dr. 15, a lecturer at University of Jember, Indonesia, to share. It is more towards sharing sessions instead of giving a lecture on TDM of aminoglycosides, and we are going to focus. The drug is gentamicin. So basically, this sharing session is more towards an introductions of the aminoglycosides, and also I have provided and prepared a case study on how to better understand the case of aminoglycosides, specifically on the gentamicin. So this is not a kind of lecture because I've given 2 hours to deliver this topic, and hopefully we can have two-way communications between me, myself in Malaysia, and also all the participants in Indonesia on what are the best practices of TDM or clinical pharmacokinetic services in Malaysia, basically, and also we also would like to know what are the practice of TDM or clinical pharmacokinetic services in Indonesia. Okay, so hopefully we can have a two-way communication and interaction at the end of these sharing sessions. So basically, my name is Safwan Hadi bin Afendi. I'm a lecturer at UniKL RCMP, Faculty of Pharmacy, Department of Pharmacy, and also a registered pharmacist in Malaysia. So before I start my sharing sessions, I just want to share with everyone here in this platform that last time I went to Indonesia on 18th of June until 23rd of June for a visit and research collaboration activities. And at that time, I was given the responsibility to attend a workshop series and also educational activities, include the lecture and sharing sessions delivered by the Vice Chancellor of UNESH, I think Prof. Bambang. And also I have given a chance to meet the lecturer at UNESH. One of it is Dr. Amrun and also Prof. Bayu. So I have been there in Indonesia at UNESH University, basically on 18th of June last year, 2023. So it was a great pleasure for me to share with everyone here online, and hopefully we can have other opportunity to visit UNESH next year or maybe this year. And if you have any intention to make a collaboration with us here, just let Dr. 15 know, and hopefully Dr. 15 can inform to me. And we have a variety of experts here in UniKL. Maybe we would like to have a collaboration with other lecturers also. So you are most welcome to do so. All right. So it was a great time to be in UNESH last year on 18 June until 23rd of June. So back to our business for today. So this is the sharing outline of my sharing session today, which is we have a total of 6 outline, and hopefully you can bear with me within these 2 hours or maybe less, okay? Because I've given a time about 2 hours to share in this topic. So number one is regarding the introduction of TDM. So what are the definition of TDM, and what are the definition and purpose or objective of having TDM services in our Malaysian hospital. And then we proceed with the pharmacokinetics and pharmacodynamics of the drug that we are going to focus today is gentamicin. So in short, what the PK/PD of the gentamicin or any drugs of under aminoglycosides. And also we are going to look into the introduction of aminoglycosides, okay, include the example of drugs under aminoglycosides. And also, I would like to share about the TDM in aminoglycosides. So what are the basics pharmacokinetics parameters that we have to know for these drugs? And also, I have provided and prepared a case study for all participants here to better understand regarding the TDM of gentamicins. And I would like to share also what are the challenges here practicing TDM in Malaysia, and also what are the future directions of TDM services. And this is my from my personal point of view. And we can conclude all sessions. And if you have any question or you would like to share something from your side, you are most welcome to do so at the end of this platform sessions. So coming to the first, coming to the first lecture outline, which is the introduction of TDM. So this slide is basically to explain to everyone here the definition of TDM, which is TDM consists of measuring drug level in biological samples, along with the clinical and pharmacological interpretations, aiming to improve prescriptions appropriateness of the patients. So this is definition by the Panazio et al. 2022. And we can see here TDM is actually one of the services provided under the Department of Pharmacy in Malaysian hospital. And I believe that it is the same at Indonesia Hospital, which these services provide services of measuring drug level in biological samples. So the drug here is referred to, for example, we have a gentamicin, and also we have another drugs or another antibiotic that we can monitor through TDM services. For example, gentamicin, vancomycin, and any other drugs in biological sample of the patient. So the most commonly biological sample that we take from the patient is the patient's blood. But also the drugs can sometimes exist in other type of sample of the patient. For example, we take a sample from the sweat of the patients, the urine of the patients. So, but in Malaysia, the very commonly used biological sample is the patient's blood, meaning that the nurses will withdraw the blood of the patients. Okay, and these services also consist of clinical and pharmacological interpretation. So once we get the result of the TDM, the pharmacist in charge or the clinical pharmacists are responsible to interpret and make assessment on the clinical and pharmacological drug of the patients, and then doing a recommendation to doctors. And all of these activities is with one aim to improve the prescription appropriateness of the patient or to improve the quality of life of the patients. So in summary, meaning that TDM is one of the services provided under the Department of Pharmacy in Malaysian hospital. Just to share with everyone here, in Malaysia, basically the TDM services was first started and provided by the Hospital Universiti Malaysia, HUSM, in 1984, and HUSM is one of the teaching hospital in Malaysia. And on that year, 1984, the TDM services was first provided and initiated by this hospital. And then later more, over the years, more hospitals in Malaysia, in the country, began offering these services, which is TDM, to patients because they see the benefits of having these services to improve the outcome of the patients. Later on, in 1987, 4 hospitals provided the TDM services, and the number of hospitals with these services increased steadily to 73 in 2005. So we can see that the demand of having TDM services in our local hospital is steadily increased over the years, started from 1987 to 2005. So basically, this is the history of establishment of TDM services in Malaysia. And gentamicin, which is a drug under aminoglycosides class of antibiotic group, was the first drug to be monitored when the service was first introduced or initiated. Since then, the service has been expanded to include any other drugs which is considered as narrow therapeutic index drug. For example, we have here, we also monitor anti-epileptic drugs, digoxin drug, theophylline, and etc. So I will share to you later what are the another drugs that we typically monitored under TDM services in Malaysian hospital. So basically, this is the introduction part of the establishment of TDM services in Malaysia. To continue the slide, TDM is also a testing or procedure that measures the amount of certain medicines. In our case here is gentamicin or aminoglycosides antibiotic in the patient's blood, and it is done to make sure the amount of medications that a patient taking is both safe and effective. So this is another goal of having TDM services, where we want to ensure the safety and effectiveness of each medication that the patient consume, especially drug that is considered narrow therapeutic index. One of it is antibiotic from the class of aminoglycosides, which is gentamicin. So as you can see here, let's say, for example, we have one patient and the patient is administered with gentamicin. And then how we perform the TDM services on that patient is, the first step is for us to do a sample collection first from the patient's body, where we commonly get the patient's blood specimen to analyze the sample. Okay, so basically the sample collections, the sample that has been collected by the nurses will be sent to our lab or our pathology lab to be further analyzed. So this is where we enter into the stage of sample analysis. So the officer or the medical lab officer at the lab will further analyze the sample that has been sent by the nurses using a different type of analysis or tools. For example, here we have chromatography analysis or HPLC, high performance liquid chromatography. And also we have another type of testing, which is immunoassays. And also we have sensors and wearables. But I think in Malaysia, we frequently use chromatography and immunoassays type of testing to detect or to identify the serum plasma concentration of a medication that we send for TDM services. But I think we don't have yet the sensors and wearables where we can actually monitor, and where we can also actually use to monitor the drug level or the serum plasma level of medication that we send for TDM services. And I would like to share also my research, which is we have been working 2 years to develop a prototype and proof of concept of our biosensor to monitor gentamicin, so which I will share later at the end of these sharing sessions. And then the sample analyzed will be then further interpreted by the person in charge. But in Malaysia, the person in charge is basically the clinical pharmacy or the pharmacist that is responsible on that patient. Okay, so they will responsible to interpret and make assessment on that result from the sample analysis, and also they will further proceed with the medical judgment. So in here, the stage of medical judgment, it also include other healthcare professional. For example, we have also doctor, physicians, nurses, and also clinical pharmacists. And after the medical judgment, we can proceed with the adjustment of drug dosage after undergo several procedures. And this stage where after we calculated the dose, what are the appropriate dose for the patients, it means that we already made adjustment on the drug dosage. And then we inform the nurses responsible, and then they will probably administer a new dose to the patients. So all of this concept is called as personalized dosage regimen, procedure of precision medicine. So basically, TDM is playing around of these activities of sample collections, interpretation of result, medical judgment, adjustment of drug dosing regimen, and also this is also called as personalized dosage activities. Okay, so hopefully you can have a better understanding on what is definition of TDM services. In Malaysia also, there is a hospital that not calling as TDM, but they are calling these services as clinical pharmacokinetic services, okay, CPS. But in general, it is the same thing. Whether it is TDM or CPS, is the same activities where we want to monitor or identify the serum plasma concentration of the drugs that we send for TDM services. So just to share with everyone here, these are some of the reference resources in clinical practice, or we probably use in teaching learning activity, even in our faculty, where we have first and second edition of Clinical Pharmacokinetics Pharmacy Handbook that was established by our Pharmacy Practice Development Division under Ministry of Health Malaysia. So basically, this is our so-called kitab when we want to practice TM services in hospital, where usually the pharmacist will refer to this handbook if they are about to perform some clinical practice related to TDM services. But also, we use this pharmacy handbook for our teaching and learning activity here in our campus. And these two first and second edition of Clinical Pharmacokinetic Pharmacy Handbook was established by our Ministry of Health, where majority of the clinical pharmacists will refer to these two handbook. But also we have so-called in-house reference book that was published by the respective hospital, the government hospital in Malaysia, where the name, for example here, I can show you the Clinical Pharmacokinetic Services CPS calculation guideline. So this is from one of the hospital in our state here in Perak, and also the TDM booklet, the 4th edition 2017, PPUKM Pharmacy. So basically this two document is the internal CPK handbook that also can be referred by the pharmacist in charge of TDM services. And for the purpose of teaching and learning, we always encourage our students, our final year students, to download this reference book of applied clinical pharmacokinetics for them to better understand the clinical consideration of the pharmacokinetics. Okay, basically we have two subjects here, whether it is a basic PK or clinical pharmacokinetics. So actually the students, we encourage the student to download this soft copy of the pharmacy reference handbook. Okay, that was published by Dori Bauer. So basically, these are the list of drugs typically being monitored in our hospital, in our TDM services. And this list consists of anti-epileptic drugs, antibiotics. For example, here we have aminoglycosides and also glycopeptide antibiotic, vancomycin, immunosuppression drugs, and others. So as you can see on the slide, we have total of 15 chapters, which referring to 15 different type of drugs that we typically monitor under TDM services in Malaysian hospital. So basically, not all drugs available in Malaysia, we have to monitor their serum concentration under TDM services, but only certain drugs which consider having narrow therapeutic index drug, NTI, that we can typically monitor under TDM services. Okay, and I believe that in Indonesia also, not all drugs available in Indonesia you have to monitor under these TDM services. Okay, but out of these 15 list of drugs, for the sake of sharing session today, we are going to focus on the gentamicin, which is falls under aminoglycosides. Okay. Since I have the opportunity to communicate with all of the participants here from Indonesia in this platform, I just want to share the TDM workflow in our Malaysian hospital, where the first step is identifying patients who need to conduct drug monitoring. So usually this step is done by the specialists or the medical doctors at that respective hospital. And then the next step that should be done by the doctors is we refer verbally through phone calls about the case that need TDM services to the pharmacist in charge. Okay, usually we have a pharmacist in charge in every ward in our hospital that is called as TDM pharmacist. So basically the doctors will call the TDM pharmacist and talk to them that there is a patient needs the TDM services in their ward. And then the further step is to review cases in the ward and fill out the TDM form completely. So this step is done by the pharmacist. So the pharmacists have to fill out the TDM form completely before further actions. And the next step is receive a copy of TDM application form and register in the TDM case register book. So this step also is done by the pharmacist, and the pharmacists also have to screen the received application form. And the next stage is usually the nurses will send the collected sample of the patients, usually the blood, for further sample analysis. So the performing of the sample analysis will be done by the pathology lab staff or the medical lab technologists that working at the lab department. And then once the analysis have been analyzed by the lab staff will send the result to the pharmacist in charge, and the pharmacist will receive the test result from the pathology lab through the system, an online system that we call as iLab system. And the pharmacists also are responsible to record the analysis result in the TDM application form, and then make interpretations and give those recommendations to specialists or medical doctors in charge for that patient. So basically, in this stage, the pharmacist in charge have to calculate the specific appropriate dose for that patient. Okay, if that patient needs an adjustment of the dose regimen, and then the pharmacist will verbally inform the ward or the doctors in charge of the decisions via phone call. And the next step is take an official result from the TDM pharmacy. This is done by the assistant medical officer or any staff available. And the last stage of the process of TDM workflow in Malaysian hospital is for documentation and file for further reference in the future, just in case the patient might be having some problems, so they will refer to the specific document and files to the respective case. So basically, this is the TDM flow in Malaysian hospital, where we work collaboratively with the nurses, with the doctors, and also the officer at the pathology lab to ensure the effectiveness of the drugs that we send for TDM services. Okay. Previously, our TDM services is all controlled by the pharmacy department, where the analysis part is also done by the pharmacist. The interpretation part also is done by the pharmacist. But nowadays, we have evolved the way how we work for these TDM services, where the analysis part of the sample collected of the patients, basically the blood will be done by the pathology lab officer at the pathology lab. And then once the result is available, that result will be further interpreted by the pharmacist in charge. So at least we have evolved to make sure that our pharmacist is capable to provide an appropriate assessment on that patient's outcome. Okay. So the second outline is regarding the PK and PD, which is the knowledge of pharmacokinetics and pharmacodynamics. So basically, there are two components of pharmacokinetics, where the first component is regarding the basic pharmacokinetics, and also the second component is the clinical pharmacokinetics. So basically, the basic PK or basic pharmacokinetics is the fundamental knowledge of basic pharmacokinetics, where we have to fully understand the concept of pharmacokinetics and pharmacodynamics of each drug that we are dealing with. For example, here, the basic concept, the key terms such as absorption of the drugs, distributions, metabolism, and excretions. So these are all the basic pharmacokinetics of the drugs, where it involves 4 different processes, meaning that once the drugs is consumed by the patients, it will further process by the GIT or our stomach for absorption process, and then distributions, metabolism, and excretion. So these are all the concept of basic pharmacokinetics. However, when it comes to clinical pharmacokinetics, we have to look into the patient's clinical manifestations, meaning that how to initiate the drugs to the patients, and how to make adjustment if the patient needs an adjustment of the drugs. Okay, so that are basically the differences between this basic pharmacokinetics and clinical pharmacokinetics. So before you go further to clinical pharmacokinetics, we have to at least have knowledge regarding basic pharmacokinetics on how the drugs is being processed in our body. Okay, because the PK means that what is the body does to the drugs, and the PD, the pharmacodynamics, means that what the body does, what are the drugs does to the body. Okay, so you have to familiarize yourself with the absorptions, with the distribution process, the metabolism and excretions, and what are the type of organ involved for each of these process. For example, here, when we talk about the drug absorptions, so most probably we are talking about our patient's gastrointestinal status or stomach, okay? Because stomach is responsible for the drug absorptions. Distributions and metabolism is most probably the liver of the patients. You have to make sure that the liver status for the patient is in a good conditions to make sure that the drug metabolism process is at the best level. And also the last stage of the drug process of pharmacokinetic is the excretion process, where this is basically you will see that it's very important for you to make sure the kidney of the patient is really working very well to ensure that the drug is excreted or eliminated properly from our body, okay, to avoid any unnecessary side effect, for example, toxicity and so on. Okay. So to continue this second sharing outline, so in pharmacokinetics we have one term here, which is therapeutic window, that's referred to range of each drug. Okay, so if I can share with you, this is the explanation about the therapeutic range or TR of vancomycin. So vancomycin is example of drugs under glycopeptide class of antibiotic. So basically we have a graph here. For example, I also provide a picture of vancomycin drugs available in our country. We have the strength of 500 mg in the form of vial, powder vial. We have to refer to the drugs before we give to the patients. Okay, so basically we have one graph here. So the graph is serum concentrations versus time and doses, where you can see the green line indicate the difference frequency of the drug dose. So we have here dose 1 and also dose 2, and dose 3 and dose 4. So in basic pharmacokinetics or pharmacokinetics itself, in order for the drugs to achieve steady state, where the drug in and drug out is equivalent, that is called as steady state, we have to at least have 3 to 5 half-life to make sure that the drug is in steady state concentrations, right? So that is the first basic understanding of the basic PK. And then also you will see the purple line here indicate the serum peak level of the vancomycin drug here, or the serum post level of vancomycins. And also you will see the red line indicate the serum pre-level or serum trough level of vancomycin drug here, where the peak level have not been shown to correlate with efficacy or toxicity for vancomycin. So most of the cases, even in our practice, it is unnecessary to really monitor the peak or post level of vancomycins if you are using this type of method. But if you are using another type of monitoring, which is AUC over MIC, the peak level is very important. And the red line here referred to the pre-level or post-trough level, where the trough level monitoring is important for this vancomycin drug because it is correlated with the efficacy of vancomycin treatment and risk of nephrotoxicity. Okay, and for vancomycins, we have to target the trough level or the pre-level according to the severity of the infections. Okay, for example, if the patient is having non-complicated infections, so the target trough level for vancomycin is between 6.9 to 10.3 micromole per liter or 10 to 15 milligram per liter. That is the target trough level of vancomycin for patients diagnosed with non-complicated infection. However, for complicated infections, for example, if the patient diagnosed with endocarditis or infective endocarditis, osteomyelitis, hospital-acquired pneumonia, meningitis, or bacteremia, we have to target trough level of that vancomycin a little bit higher compared to non-complicated patients, where we have to make sure that the target trough level or the pre-level of vancomycin is within 10.3 to 13.8 micromole per liter or 15 to 20 mg per liter, because that patient is diagnosed with complicated infection. So we have to make sure that we target a bit higher trough level of vancomycins. Okay, and for vancomycin case, we have to bear in mind that only the trough level is correlated with the efficacy and toxicity case of vancomycins. Okay, if the trough level is out of the range, which is above 13.8 micromole per liter or above 10.3 micromole per liter, we have put the patient at risk of having toxicity. For vancomycins or gentamicins, the most commonly toxicity associated with this drug is nephrotoxicity and also ototoxicity. So basically, this is slide trying to explain about the definition of therapeutic window. Okay. Since our topic for today is introduction to aminoglycosides, so we are going to focus only one drug under this class of antibiotic, which is gentamicins. In fact, we have other type of aminoglycosides. We have gentamicin, we have amikacin, and we have methylmycin, and also tobramycins. And gentamicin is an aminoglycoside antibiotic that is frequently used in the treatment of several gram-negative infections. And also, some of the indication is used for gram-positive bacteria, okay, or gram-positive infection. So basically, gentamicin is aminoglycoside class of antibiotic that is very commonly used in the treatment of patients with gram-negative infections, okay. And if we look into the microbiology part of the gentamicins, is actually gentamicin is an aminoglycoside derived from Micromonospora purpurea, a genus of bacteria of the family Micromonosporaceae. And this genus name was first proposed in 1923 by Danish physicians named as J.P. Oskov. And as I mentioned before, that some of the gentamicin is also used in the treatment of gram-positive bacteria, where we frequently use low dose of gentamicin in combination with other type of antimicrobial agent. For example, we combine between gentamicin and the beta-lactams, or we combine gentamicin with vancomycin or glycopeptides against gram-positive bacteria for the treatment of gram-positive infections. For example, if we have one patient diagnosed with infective endocarditis, so basically the treatment management is by using a low dose of gentamicin in combination with the beta-lactams class of antibiotic drugs. And when we have this type of treatment approach, it is called as synergistic dosing. Okay. So to continue the sharing sessions, this is the indications of having gentamicin for the patients, and also how the aminoglycoside or gentamicin work on that patient. So basically, the indication of patients that's supposed to be started with gentamicin, where they have several clinical scenarios such as bacterial septicemia, endocarditis, or infective endocarditis, i.e., meningitis, urinary tract infection, UTI, gastrointestinal tract, including peritonitis, and also skin and soft tissue infection, SSTI. So, if you are, I suppose that you are familiar with the term of indication, meaning that what are the reasons of patients started on that drugs. Okay. So the indication of patients started on gentamicin is due to these several clinical scenarios, as I mentioned before. And when we look into the mechanism of action of gentamicins on how aminoglycoside work, is actually gentamicin is a bactericidal effect, meaning that it's directly killing the bacteria. Okay. Just to recap, we have two types of antibiotic, whether it is a concentration or time-dependent antibiotic, and also whether it is a bactericidal effect or bacteriostatic effect. So for bactericidal effect, it means that the antibiotic directly kill the bacteria. Okay. So how does the gentamicin directly kill the bacteria, or by having bactericidal effect, is when we look into the MOA of these drugs, actually the gentamicin will bind to 16S RNA at the 30S ribosomal subunit, and then it further inhibit the protein synthesis of that specific bacteria, which leads to misreading of messenger RNA or mRNA, where when that protein or when that bacteria having misreading of mRNA, it will further lead to dysfunction protein productions that we call as faulty proteins. So when there is no appropriate proteins for the bacteria to survive, there is no the bacteria is not able to survive, and it will be killed directly by the gentamicin. So this is the mechanism of action of gentamicin on how it exerts as bactericidal effect type of antibiotic. Okay, so I believe that since you are the pharmacy students, the final year pharmacy students, and some of us continue our study in master, and I have been informed by Dr. 15 that the lecture, pharmacy lecture also in here. So it is very important to know the MOA, the basic concept of MOA for gentamicin. Okay. Right. So, and the last part of this sharing sessions for outline number 3 is regarding the toxicity concerns. Okay. So this is where we have to look into the relationships, where we have to know the first part is concentration efficacy relationships, and then later part we will see the concentration toxicity relationship. And majority toxicities associated with gentamicins, including nephrotoxicity, where there is damage at the kidney of the patients, and also ototoxicity. Okay, meaning that the drugs giving a bad effect to this type of area at the kidney area and also the ear area that we call as nephrotoxicity and also ototoxicity. So the first part, we look first at the concentration efficacy relationship, where this type of gentamicins anti-aminoglycoside group is considered as concentration dependent bacterial killing and also exert as a bactericidal effect. And the minimum inhibitory concentrations or MIC of gram-negative bacteria are usually less than 2 microgram per ml for gentamicin and tobramycin, and 8 microgram per ml for amikacin. So each of the bacteria having a different value of minimum inhibitory concentration of MIC. For example, if you want to kill the bacteria using gentamicin and tobramycins, we have to make sure that we kill the bacteria having MIC less than 2 microgram per ml. If we are dealing with the bacteria that is having more than 2 microgram per ml, it will not kill the bacteria if you are using gentamicin or tobramycins. Okay, and gentamicin exerts a significant concentration dependent post-antibiotic effect, or in short, we call it as PAE. But how does the gentamicin specifically exert this type of PAE effect? Okay, if you can look here, I have provided 2 types of graph, where the first graph is explained to the post-antibiotic effect. So we have graph here, the plasma concentration of gentamicin versus hours or time. And then there is a dotted line that indicates the minimum effective concentration or MIC. Okay, so the first dose is given. Let's say the first dose is given to the patients, and then the graph will indicate increasing steadily and then going down. Okay, so that is the first line, indicate the first dose. So when there is no second dose, the blue line will going down steadily until it reached below the dotted line of MIC. So even though the drugs is not given for the second dose, is still having an effect of bactericidal effect, because this is considered as post-antibiotic effect, meaning that even though the serum plasma concentration of gentamicin is below MIC, it still has effect as antibiotic, because this antibiotic is having post-antibiotic effect. Okay, which is up to 6 to 8 hours post-antibiotic effect. So this is the specialized, the special things about aminoglycosides or gentamicins, because it exerts the post-antibiotic effect. Okay, so that is the concentrations efficacy relationship. Now we are going to look into the concentration toxicity relationships of gentamicins, where the most commonly happening of toxicity is nephrotoxicity, which are usually reversible conditions, where we can reverse this condition of nephrotoxicity. And another type of side effect of gentamicins is ototoxicity, which is usually irreversible conditions, where it affects the auditory and vestibular function of the patients. Okay, and aminoglycosides or gentamicin nephrotoxicity manifests clinically as non-oliguric renal failure, with a slow rise in serum creatinine and hypoosmolar urinary output developing after several days of therapy. It means that the condition of nephrotoxicity due to the high level of gentamicin can happen to the patients, as in the patient will show a clinical manifestation of non-oliguric renal failure, and we can see that there is an increased pattern of serum creatinine. So the serum creatinine is the biological marker that we frequently monitor if we started patient with gentamicin or vancomycin or any drugs that is excreted through kidney. and also hypoosmolar urinary output. So you have to put in your mind that how we monitor the kidney status of the patients by looking at the serum plasma, by looking at the serum creatinine, then we can calculate the creatinine clearance of the patients. Okay, and aminoglycosides also can cause a permanent vestibular or auditory toxicity, and this ototoxicity occurs for about 2% to 10% of patients treated with aminoglycosides. So basically, this is the slide where you can learn about the expected toxicities happen due to exit level of gentamicin, which are nephrotoxicity, something bad happened to the patient's kidney, and also ototoxicity, which something bad happened to the patient's ear status. So sharing our number 4, where we look into the TDM in aminoglycoside or TDM of gentamicins. So the first picture is the rationale of having TDM services for gentamicins, and the second picture is what are to be monitored when the patients administered with gentamicin or any other drugs that is considered narrow therapeutic index. So we put our focus on the picture 1. So picture 1 is a graph that emphasizing gentamicin narrow therapeutic index and the potential for serious toxicity. So as you can see a graph in picture 1, you can see a graph serum concentrations versus half-life or hours, and then we have 3 doses there, and then the steady state where the therapeutic range of the drugs. Okay, for this case, it's gentamicins. And TDM services is very important for us to make sure that the serum plasma concentration of gentamicins falls within the expected therapeutic range. Okay, if the serum plasma concentration of the gentamicin is out of the therapeutic range, meaning that the post or the P level is higher, it will lead to the toxic range, and the patient most probably will get nephrotoxicity or ototoxicity. And if we cannot ensure that the serum plasma concentration of gentamicin is not within therapeutic range, but it is below than therapeutic range, it means that we have put the patient at the subtherapeutic range conditions, meaning that if we still give the gentamicin, even though the level is subtherapeutic, the patient will not show any positive outcome from the gentamicin, meaning that the septic parameters still going on, the patient still having fever, and then the white blood cells still increase, and so on. So it is very critical for us to make sure that any drug that we give to the patients, especially the drugs that is narrow therapeutic index, is their serum plasma concentration is within therapeutic range. Okay, not out of the range or not below the therapeutic range, because it will lead to toxicities or toxic range condition, and also it will lead to subtherapeutic level or subtherapeutic range. Okay, so that is the rationale of monitoring the gentamicin through TDM services or clinical pharmacokinetics services. Okay, so how we monitor the performance of that gentamicin is by looking, basically one of the parameters is by looking specifically at the peak level or post level of gentamicins, as well as the trough or pre-level of gentamicins. Okay, so you can see that the peak level, the picture number 2, the peak level is the highest concentration of medications or gentamicin in our patients, and the trough level is the lowest concentration of gentamicin in that patients. Okay, so you have to make sure that the peak or post level and the pre and trough level is not exceeding the minimum toxic concentration range, and also it's not below the minimum effective concentrations, and it must be appropriately fit under therapeutic range index. Okay, to ensure that your drugs is effectively working on your patients. So this is to better understand the TDM of gentamicins. So if I can sketch on this graph, Dr. 15. So I will okay. So basically, I'm using a pen to illustrate the post and peak level of gentamicin and pre and trough level of gentamicins, because I've explained before, I might afraid that some of the participants will not understand where is the location of pre and post concentration of gentamicin and post and peak gentamicin and pre trough gentamicin. So I'm using pen to illustrate on the graph here. Okay, so as you can see, there is a table here indicate the time to sample. Okay, time to sample and also the sampling time of the gentamicin and how we interpret the pre and post level of gentamicins. Okay. So for gentamicins, if we give the drugs to the patient by multiple daily dose, MDD, so the way how we sample the pre and post level of the patient is, if it is pre-level of gentamicins, we must take just before, so this is the pre-level, we must take the sample from the patient just before or within 30 minutes before the next dose of the patients. Okay, so that is the definition of the pre or trough level of gentamicins. However, for post level or peak level of gentamicins is defined as 30 minutes after completion of 30 minutes infusions, meaning that 1 hour after infusions, that is where we have to take for the post or peak level of gentamicins. So as you can see here, we have a graph, gentamicin level or concentrations, probably in micromole per liter or milligram per liter, versus time in hours. So we have 48 hours here. And also we have gentamicin level concentrations. Okay. So, right. So just imagine we administer about 4 to 5 doses to the patients, where we have here dose 1, and then we have here dose 2, and we have here dose 3, and we have here dose 4. Okay. And this is probably dose 5. So in the basic pharmacokinetic concept, we have to reach at least 3 to 5 half-life to achieve steady states, meaning that this is the first dose, second dose, third dose. So probably these gentamicins will reach steady state concentration at the 4 doses or 5 doses. So this is where the steady state concentration of the gentamicins, okay, meaning that the amount of amount of out of the drug is equivalent. All right. So back to the table here, the pre-level is just before the next dose or 30 minutes the next dose. So if the first dose is here and the next dose of the first dose, which is the second dose, is here, so the pre-level or trough level of the gentamicin is probably here, 30 minutes before the second dose. Okay. So probably the pre-level or trough level of gentamicin is here. So this one is considered as pre-level, where it is before the next dose or before the second dose or 30 minutes before the next dose or second dose. So this is the pre-level of gentamicin that we are going to take for the sample. So usually the nurses will take the sample from patients. And the post-level or peak level is by definition 30 minutes after completion of 30 minutes infusions. So meaning that it is 1 hour post infusions. So probably since this is the second dose or the next dose, so probably the 1 hour post is here. So this one is the peak level of the drugs. Okay. So this is the sampling time of gentamicins, where it is very crucial for us to comply with the time of pre or trough level and peak and post level. All right. Okay. So basically, this is the therapeutic range of gentamicins and also amikacins. Okay. So usually we target the trough and peak level of gentamicin according to this table. Okay, and this also depending on the method of drug administration for your patients. Okay, for example, here we have neonates, we have pediatric patients, adult, and synergy dosing. So it's depending on the type of the patient that you are dealing with. It is varied the range of gentamicin and amikacins. Okay. So now we come to the case study, the second last sharing outline for today's sharing sessions, where in this case study, I will provide a real case study where we can share among each other the patient background and also the initial dosing that the patients started before, and also how we monitor the drugs and how we make the dose adjustment and what are the outcome and follow-up on the patients. Okay? So before I come to the study case, I would like to share very fast, very immediately on how we calculate the dose initiation of gentamicin and also how we make the dose adjustment for gentamicin. What are the steps involved and what are the formula or equations involved in each step on how we make a dose initiation and dose adjustment for gentamicin. Okay, and we proceed to the case study because I believe that we have learned about the basic calculation part of gentamicin at your university. So this sharing session is just to recap what are the steps or equation involved for dose initiation and what are the steps and equation involved for dose adjustment. And in later part, we can go through the case study together. So basically, how we determine the dose initiation of patients started on gentamicin. So we have several dosage determination methods. Number one is Sawtry-Daske method, linear pharmacokinetic method, and also pharmacokinetic PK concept method. So basically, we have here the equation involved for Sawtry-Daske method, and we are not going through the method number 2 and number 3. And all of these determination methods is basically having one or two different objectives where we want to achieve a therapeutic level of the drugs, and then we want to avoid any subtherapeutic level or dosing error, which can lead of having under-treatment condition, and we want to make sure that the loading dose to achieve faster steady-state concentrations. So using the Sawtry-Daske method, this is the first step, step number 1, where if you want to estimate the initial dose or dose initiations of gentamicin based on the population pharmacokinetics parameters, not the patient's parameters. Okay, so basically we can use any information of the pharmacokinetic profile from the population pharmacokinetics parameters, not the patients, because we want to start the drugs to the patients, not making any adjustment yet. Okay, so for the sake of dose initiation or dose starting dose of gentamicin, we can follow this step. And I'm not sure whether this step is the same practice for of the pharmacists at Indonesia or not. Maybe we can share each other after these sharing sessions. So for step number 1 on how you can make a dose initiation of gentamicin is first the pharmacists have to decide or determine the dosing weight of the patients. Okay, because we are dealing with different type of patients, which is very different in terms of physical appearance. Okay, some of the patient is very skinny, some of the patient is very fat, and some of the patient is very obese. So it is not fair for us to treat everyone the same if you want to make dose initiation or if you want to decide the dose for gentamicin if they are not started any drug yet for gentamicin. So how we can decide the dosing weight is first to determine the patient actual body weight or ABW in kilogram, and then we have to decide the ideal body weight of the patients. So there is a formula here if you want to calculate for IBW of male patients. So that is the equation responsible. If your patient is female, so that is the equation responsible to calculate the IBW. And then you have to compare ABW to IBW in order for you to get what are the dosing weight that you have to use throughout the equations after this. Okay, so this step is very important for you to make sure that you are using an appropriate and correct dosing weight for your patients before you calculating the rest of the step after this. Okay, and then the second step is for you to decide the volume of distributions of the gentamicin for these patients. Okay, using the population PK parameters, you can estimate or calculate the volume of distribution for gentamicins. So the equation is very simple and direct, where VD or volume distribution in the unit of liter is equal to population VD liter per kg times dosing weight. So basically for gentamicins, the population volume distribution value is between 0.25 to 0.5 kilogram per liter. But 0.25 to 0.3 liter per kg. So you can use that value to calculate the patient's VD for this gentamicin piece. And then the next step for you to estimate the creatinine clearance of the patients. Okay, so this is the equation from the top equations. Okay, so and if you want to know the status of the patient's kidney profile, you can calculate their creatinine clearance so that you can classify your patient whether they are having a good kidney status or not, because this drug is basically 100% unchanged excreted through the patient's urine. So you have to make sure that your patient's kidney profile is at the best performance. Okay, because we try to avoid any drug accumulated in the patient's body. Okay. The next step is step 4, where you have to estimate and calculate the gentamicin clearance. So for gentamicin, the clearance equation is equal to creatinine clearance times 60 minutes of 1000 ml. Then you can get the clearance of gentamicin. And this is to enlighten everyone that for the creatinine clearance determinations, practically we use Cockcroft equation because number one, the equation is very simple, convenient, and practical to be used in our clinical practice. But now we are moving towards CKD EPI equations formula if you want to decide the renal performance of the patients. Okay. And then step number 5 is where we have to estimate the elimination rate constant or KE of the gentamicins. The formula is shown on the slide. And then step number 6, we have to estimate the half-life of the gentamicins. And we have to decide the target therapeutic range for our drugs. In our case, it's gentamicins. So it depends on the dosing method, whether we use multiple daily dosing or NDD, or extended interval dosing method, or single daily dose for gentamicin. So here, the target therapeutic range for the gentamicins, if it is free, should be below than 2 mg per liter. Okay, for endocarditis patients, and if it's post for pneumonia patient, is between 8 to 12 mg per liter. Okay, so basically the students or the pharmacists need to remember all of this value because it's very important to be put in the equations after this. Okay, so this is the target therapeutic range for amikacin, and this is the target therapeutic range for gentamicin, netilmicin, and amikacin if we are giving the drugs by single daily dose to the patients. Okay, single daily dose meaning that 24 hourly. Okay, but multiple daily dose, it is whether it is a 12 hourly or 6 hourly or 8 hourly. And next step is step number 8, where we have to estimate the initial dose or the new initial dose by deciding the target Cmax. And then number 9 is estimate the expected Cmax and expected Cmin concentration of the gentamicins. Okay, and after we make the dose initiations, and just in case that the patient needs dose adjustment, so these are all steps involved or equation involved on how we can actually decide the dose adjustment of the gentamicin for the cases. But for the dose adjustment, we have to use whatever information it is based on patient-specific pharmacokinetics parameters, no more population PK parameters. Okay, meaning that whatever you use is the VD of the patients, the clearance of the patients, and etc. So for making those adjustments, step number 1 is almost the same with the step number those initiations, where the step 1 is estimate the KE. Step number 2 is estimate half-life of the drugs. Number 3 is estimate Cmax and Cmin concentrations. Step number 4, determine the volume of distributions, the VD. And step number 5 is for you to calculate the new dose of the patients, okay, and making those adjustments. Okay, so basically, there are the equations or steps involved for the dose initiations of gentamicins and dose adjustment of gentamicins. So I believe that it is very difficult for you to understand each of the equation and stuff involved. But I think if you have any further information or further question after this, you can just personally contact me through WhatsApp or email, and maybe you can have more exercise on how to make those initiation and those adjustment for this case of gentamicins, because I have prepared numbers of case study related to gentamicin dose initiation and dose adjustment. Because for the sake of sharing sessions, I believe that we don't have enough time within these 2 hours. So maybe you can have, or maybe you can schedule another hours after this. Okay, so now we go through the case study related to aminoglycoside or case gentamicin. So I'm sharing another document. Can you see my document? 2015.
Yes.
Okay, so I hope everyone can still stay with me and bear with me, because we have come to the end of the sharing session. So before we end our sharing session today, I just want to share a case study report on gentamicin as antimicrobial agent in infective endocarditis with liver conditions. So basically, this is a case of TDM case study or clinical pharmacokinetic service study, where the patients prescribed with the gentamicin for indication of synergistic dosing. Okay, and we are not going through all the information stated in the case report. So basically, this is the abstract of the case, and then the introduction part of the case. So I think within these hours, we can read together the case presentation of this case study of gentamicin. Okay, so actually, the case presentation or the case report, it is a 22-year-old Chinese man transferred from hospital A to hospital B with recent operation post-excisional biopsy of nodular fasciitis on the right corner of mouth by dental surgery team on 11 of December 2023 last year, and discharged well with follow-up under clinic Kesihatan. So basically, the patients recently had an operation of post-excisional biopsy of nodular fasciitis. In short, that we call as a dental surgery procedure. Okay, and the patient was presented with pre-mobility activities, daily living independently. So the patient was presented with pre-mobility activities, daily living independently. However, the case referred to Hospital B for further investigations on left atria myxoma presumed infective endocarditis. After patient complained dyspnea for the past 2 weeks with bilateral edema, paroxysmal nocturnal dyspnea, and off fever for past 2 days during follow-up in clinic Kesihatan. So basically, the patient was presumed infective endocarditis. So this is where we have to use gentamicin to treat the infective endocarditis. Okay, but it is only presumed infective endocarditis. During the bedside echo, observed thrombus in the left atrium with a good contractility. And further information stated that the lab examination showed a normal level of blood urea of 5 millimole per liter and total white count of 10 to the power of 9 millimole per liter, creatinine, WBC, and also a normal temperature of 37 degrees Celsius. However, the hemoglobin and sodium level were slightly lower than the normal range, which were 10 gram per liter and 129 milliequivalent respectively. Higher reading was recorded in total bilirubin, ALT, AST, which indicate the patient might be having liver impairment or liver damage. Okay, something happened to the liver tissues of the patients. Despite that, the ALP level is still within the range. Thus, the patient diagnosed progressed to presumed infective endocarditis, left atrial myxoma, and transaminitis secondary to liver condition. So that is the recent condition of the patients, where the patients had the presumed infective endocarditis and also with the transaminitis secondary to liver infections or liver congestions. So what are the treatment management give to the patient is initial treatment started with IV gentamicins or intravenous gentamicins with the dose of 80 mg TDS or TIT, meaning that 8 hourly, and IV enoxaparin for 4 hours to manage presumptive infections of endocarditis. The blood culture is taken at 3 different sites to identify the positive agents, and they finally identified the gram-positive Streptococcus aureus was detected. So basically, this is the time where we have to use the synergistic dosing of the gentamicins because, as I mentioned in the previous slide, gentamicin is not only indicated for gram-negative, but this also can be used for gram-positive infections. In this case, is due to Streptococcus aureus. So hence, the synergistic dosing was described where we combine together gentamicin with the beta-lactams, which is intravenous benzyl penicillins. And then prescriber started IV paracetamol, 1 gram instead, and continued with the current synergy antibiotic. And the synergy antibiotics regimen prescribed for these patients are IV gentamicins, 100 mg BD, and IV benzopenicillin for MU every 4 hours. So this is the synergistic antibiotic regimen for these patients, where it's combined between gentamicin and beta-lactams antibiotic plus. And then penicillin plays the role of bacteriostatic by breaking down the beta-lactam ring to allow IV gentamicin enter and express its bactericidal action or effect. So this is the rationale of combining between gentamicins and beta-lactams, where the beta-lactams will play a role to break down the beta-lactam rings, and by having that, it will allow the gentamicin to enter and exert its effect as bactericidal actions. And the case study goes on, and the last dose given for the patient is IV gentamicin 150 mg OD. So how we calculate the dose adjustment of gentamicin for this case is actually using Excel TDM spreadsheet that was prepared before. So that is the case study. So now I'm sharing the calculation part of gentamicins on how we make the dose adjustment for this case. Okay, so basically, this is the Excel sheet or TDM spreadsheet that we use to calculate the dose adjustment of gentamicin for the case study, where the Excel sheet consists of patient's demographic. So where you can see that it listed out the personal information of the patients. It include the name of the patients, registered numbers, IC numbers, diagnosis, the current diagnosis of the patients, which ward that the patient admitted, and age, weight, height, and BMI of the patient. So as you can see here, the age, weight of the patient, height, and BMI is very, very important for you to obtain before calculating the dose adjustment of gentamicin, because we are dealing with the dose calculations, right? And then it is also outlined the latest lab result of the patients, where the parameters that we have to look into is blood urea, sodium, potassium, creatinine level of the patients, albumin, culture and sensitivity test result, temperature, and etc. etc. So in here, for this case, the blood urea, the CRP, ALT, and ST is out of the normal range, meaning that it is high. So the one that is below the normal range is the yellow, indicator yellow, where the sodium and also the albumin. Okay. And then move on to the medication that the patient started was IV gentamicins 80 mg 8 hourly. So this is the original dosing regimen for gentamicin for this case, okay, where it was started on 10 a.m. okay, on 31st of December last year, and the last dosing date is 1 January 2024 this year. Okay, so the last dosing time is 10 a.m. and infusion is 11 a.m. And then the lab report showing that the pre-sample or the pre-concentration or the pre-level of gentamicins is within the range. Okay, for this case, we must ensure that the pre-level is below than 2 mg per liter. But for these patients, it's managed to get 1.95, which is below than 2.2 milligram per liter. But unfortunately, the post level or the peak level of gentamicin for this case is below the therapeutic range of post level for this case, where it should be expected within 5 to 10 mg per liter. But for this case, the patients managed to get below than 5 to 10 milligram per liter, which is 4.22. So it leads to sub-therapeutic level of the post level. And then using all the parameters from the patients, we have to calculate the PK parameters, which include the creatinine clearance of the patients, the elimination rate constant, the KE of the patients, half-life of the patients, the Cmax and Cmin of the patients, and also the patient's volume of distributions. Okay, because in making those adjustments, you are not allowed to use the population PK parameters, but instead you have to use the patient's pharmacokinetic parameters. Okay, in order for you to decide the creatinine clearance, half-life, and BD. And after calculations, the new dose that should be given to the patients based on the current condition of that patient is 100 mg 12 hourly or 100 mg BD. Okay, and the new Cmax and the new Cmin or the new pre and post level is okay within the range. Okay, within the range, meaning that the Cmin or the pre-level is below than 2 milligram per liter, where it shows here 0.92, and the post-level or Cmax level is within 5 to 10 milligram per liter, where shown here is 5 to 5.19. Okay, so the pharmacist assessment and recommendation on that time, on that day, is actually the patient's experience sub-therapeutic level because of the post-level is not within the range. And the pharmacist, based on the calculations, the pharmacist recommend and suggest to change the dose of gentamicin originally from 80 mg to 80 mg TDS to 100 mg BD 12 hourly, starting on the next day, and they have to monitor the pre and post level on the third dose on Thursday, 4 January, 6 a.m. Okay. So this is basically the practice of TDM services in Malaysia, where if we have given a new dose to the patients, we have to re-monitor back the pre and post level probably after the third dose, okay, of that new drugs. Okay, and this is the calculation on the next coming day, where the calculation part of the newly given dose to the patient, which is 100 mg 12 hourly. Okay, so all the table on the left is just the same. Okay. And then the things that are different here is the current regimen for the gentamicins, which is it is not anymore 80 mg TDS, but it is changed to 100 mg 12 hourly or BD. And then they take the sample. Unfortunately, the pre-level is for this turnaround, our target range is for the pre-level must be below 1 mg per liter. But unfortunately, the patient's value of pre-level on this day is above than 1 milligram per liter, which is 1.43. And this is exceeding the therapeutic range of pre-level for the gentamicins. Okay, and but the post-level is within the range as expected, which is 3 to 5 mg per liter. And this is the range of gentamicin for this day is quite different between the previous day, because this is the therapeutic range of synergistic dosing for gentamicin with combination of beta-lactams. Okay, so after calculated, the new dose should be is 160 mg, 24 hourly or once daily OD, and the expected Cmax and Cmin is okay, which is the Cmax or the post level is within 3 to 5 mg per liter, and the expected Cmin is below than 1, which is 0.467 milligram per liter. So at the end of the assessment, the pharmacist recommendation part, where they written here, actually the dose given for the patients of 100 mg 12 hourly is a potential toxic level dosing, and the pharmacist suggests to change the regimen to 160 mg once daily or 24 hourly starting tomorrow. And as usual, if we given a new dose to the patients, after making the dose adjustment, we have to remonitor back the pre and post level by taking a new sample. Okay, so basically this is a case of dose adjustment of gentamicin with gram-positive bacterial infections. Okay, in this case is infective endocarditis. So I'm back to my slide, right? So we have gone through the calculation part and equation part of dose initiation and dose adjustment, and also we have gone through the case study of gentamicin. So now continue to the next sharing outline, which is what are the challenges and future direction of TDM services in Malaysia. So if we look into the limitations of current TDM practices in Malaysia, actually there is a lot limitation and challenges. So one of it is variability in drug metabolism between patients, because some patients is different in terms of their gender, in terms of their head body weight, in terms of their age, in terms of their contributing disease, and also the organ functions, disease process, environmental matters, and also include the genetic difference that we call as genetic polymorphism. So that is from my belief that this is number one challenges or limitations that we have to aware of, which is the variability in drug metabolism between the patients, okay, or genetic polymorphisms. And the second challenges or limitation is frequent blood sampling, because the blood sampling procedure is depending on the type of drug regimen for the patients. Okay, so some patients might be having very frequent blood sampling procedure in a day. Okay, up to 2-3 blood sampling in a day. So this will cause inconvenience for the patients and also for the patient's family members, because when you take a very frequent blood sampling from the patients, it will lead to unnecessary outcome, which is the inflammation and clot due to trauma of the vein or thrombophlebitis, and also catheter in vein causing redness and inflammations. Okay, especially for patient that is special populations. Okay, if you take a blood sampling procedure from patient that is very small, for example, neonates or pediatric patients, or patient that is very in the category of geriatric. So geriatric patients and neonates is fragile patients, because we have to really take care of this procedure if you want to avoid any unnecessary outcome to the patients. One of it is thrombophlebitis. And the last, I think the limitation is the lag time between sampling and result availability. So between the lag time of sampling and the result availability, the patient might be progressing very well, and they might having worse condition of infections between the time of lag time and also the result availability. So talking about the future directions and advances in TDM, so I think this is the last 2 slides of my sharing sessions. Actually, I've been working for almost 2 years in trying to my team and I have been working for about 2 years in developing a prototype or proof of concept of a sensor or biosensor to monitor the TDM drugs invasively. Okay, meaning that instead of performing blood withdrawal procedures by punching out the patient's vein, we are trying to monitor the drugs using biosensor, which can be considered as non-invasive monitoring technique. Okay, so this is our problem statement. Usually, we further divide it into whether the TDMs or the blood sampling monitoring is performed in invasive monitoring technique or non-invasive monitoring technique. So basically, the TDM services or the CPS services in Malaysia is considered as invasive monitoring technique, where the patient have to provide a specific amount of blood to the nurses. Okay, but the non-invasive, we just monitor the blood level using biosensor, meaning that the patient doesn't need to provide any specific amount of blood to the nurses in order to identify the serum plasma concentration. So that is considered as non-invasive or biosensor, through biosensor. So this is what we are trying to develop, a prototype or proof of concept using a biosensor or wearable device to monitor and identify the serum plasma concentration of gentamicin. Okay, because we are working on gentamicin, so Alhamdulillah, we have come up with a proof of concept and a prototype of wearable device. Okay, for detecting gentamicin in the patient bloods. Okay, especially for neonates and PICS patients. Okay, so as you can see here, the lab-on-a-chip circuit schematic diagram show different components that we use in our prototype, where we have here the MAX 3013102, ESP32, and also the OLED display SSD1306. So these are all the components that we embedded into our proof of concept or prototype to identify the wavelength of the gentamicins once it reaches the blood circulation of the patients. Okay, and the picture on the right of this slide is basically what are the products that we expect to produce at the end of this research grant. Okay, which is a point of care monitoring, or POCM, of serum plasma concentration of gentamicin drugs. So we have an objective to at least produce a wearable device where that device can be wear by the patients, and then the patient's serum plasma concentration of gentamicin can be monitored and identified using this wearable device. And the patient no more to provide any sample like blood and urine or etc. Okay, so just to share with you that this is our team and our research students in our team. And our team consists of researchers from our campus, our own campus and faculty, and also collaborated with the lecturer at the electronics technology sections, UniKL BMI. And also we would like to extend our gratitude to our partners in the chemo and biosensor group, Universiti, Dr. Amrun, Dr. Bambang, for providing inputs on our research action before. Okay, so basically this is the prototype, and we are trying to proceed further to validate the prototype in the clinical trial setting. Okay, so as a conclusions, the summary of the key point of sharing session today is we have to bear in mind the importance of TDM services in ensuring the effectiveness and safety of the drug therapy, which also include the antibiotic, the antidepressants, immunosuppressant, etc. Particularly for this sharing session is aminoglycosides for gentamicins, and the clinical value of TDM in personalized medicine and its role in improving patient outcome. So there are many ways to improve the patient outcome. So one of it is through research and development. So in Malaysia, we have one document that is called as Pharmacy Research Priorities in Malaysia, where it's outlined 5 different elements or domain where you can join venture into research and collaboration. So one of the domain is domain number 2, where my research is in line with the domain number 2 in monitoring and evaluating the outcome of the patient through a biosensor device. And I can say that this is kind of innovations for TDM services, because we are trying to develop a non-invasive way to monitor the serum plasma concentration of gentamicins, especially for PICS and neonate patients. And I believe that in Indonesia also you have your own document that you can refer in order for you to join in any research activities. Okay, and with that, I end my sharing sessions. Thank you very much for listening to me within these 2 hours. And I'm happy to receive any questions, or if you have anything that you want to share, you can do so. Thank you very much. Pass over back to you, Dr. Fikin.
Thank you very much, Thank you very much, Mr. Nur Safwan. I think it's very exciting lecture about the TDM, therapeutic drug monitoring, especially in aminoglycoside gentamicin. So we still have time to discuss. Please, you can raise your hand or write in the chat box with you have the question for Mr. Nur Safwan. Okay, I think we have one student, Mr. Nur Safwan. All of this student is undergraduate student mostly, and some of them is the master students in clinical pharmacy. So okay, maybe the first question for Nur Sidki, please. You can. So Sidki is still in Vietnam, right?
Yes.
Doing his
Yes.
experience
One month
for
ago.
thesis.
Yes.
Please, Sidki.
I have several questions for Mr.
Nur
Mr.
Safwan.
Yeah, Mr. Safwan. For the first, I want to make apologies if my English is not good. So but I will try in English. I have three questions, and I think I want to make congratulations for the prototype. I think it is like some smartwatch, and
Yes.
it's very interesting to it's very interesting to learn about this in Indonesia. I think especially in University of Jember. And my question is for the first, how to determine the dosage of vancomycin or other aminoglycosides in patient with metabolic disorder and neonates or newborn, particularly based because based on my experience working in hospital and possible in most hospital in Indonesia, blood drug level monitoring is not performed. This is number one for my question. And number two, you say or you mentioned earlier that to calculate the national dose for aminoglycoside drug, we shall not use individual pharmacokinetic profile, but rather population pharmacokinetic profile. Does every population have the same pharmacokinetic profile, or as other population in the world, or not? But if they different, how do we determine the population size to establish the pharmacokinetic profile of a region? And the last question, how the relationship between medical doctor and pharmacists, especially clinical pharmacy in Malaysia, so in patient care, I mean in terms of rules, authority, and responsibility, and do pharmacists have special rules, authority, and responsibility in patient care, especially in determining drug medication use? Because in Indonesia, because I think in theoretical is same with Indonesia, but for the real in hospital is not like this. Yeah, this is, and yeah, thank you. This is my question.
Okay, so thank you very much, Bapak. Apa nama dia? Bapak Noir Sidki ya.
Sidki, Nur
Thank
Sidki.
you.
Okay.
Thank you, Mr. Sufyan.
Okay, thank you very much for the questions given by Mr. Sidki. So, if I can recap back your questions correctly. So, the first question is you are asking about how to determine the dose initiation of drugs, especially for kids, for neonate patients. And the question number two is the basic pharmacokinetic profile of the drugs. Okay, and number three is how is the pattern of relationship between the professional in Malaysia, between the doctors, the pharmacists, and etc. So actually, I'm not an expert in TDM or clinical pharmacokinetic services, but I'm teaching this subject, and also I have an experience before doing clinical attachment at a hospital during my professional registered pharmacist time or HO time or training time right after graduations. So for the first questions, how you determine the dose initiation of your needs when the blood sample is not really available at your hospital, especially the concept of dose initiation and even dose adjustment for each drugs listed under TDM drugs or the drugs that is considered narrow therapeutic index drugs, NTI drugs. By whole by group, we must at least obtain their sample from the patients. Okay, whether the biological sample is in the form of blood or urine or any other available samples, you have to make sure that the sample is available for the lab department officer to analyze the sample. For example, in Malaysia, we frequently take sample from the patients in the form of blood, where the nurses withdraw the blood, and then that blood will be sent to the lab department for further analysis using maybe HPLC or chromatography or biosensor. Okay, and then based on the result of the fresh blood specimens, then only we can know how much exactly the minimum concentration of the serum plasma concentration of the drugs in the patient's body. Okay, then only you can decide what are the appropriate dose given that should be given to the patients for the dose initiation or dose adjustments. And this is the same throughout the populations, whether you are dealing with neonates patients or PIDS patients or geriatric patients. The fundamental concept is we must obtain the fresh blood specimen from the patients, okay, for further analysis. If not, we don't have any information regarding what are the value for the pre and the post level of that sample for that specific patients. Okay, I hope that answered the question number one. And number two, the basic PK profile of the drugs. Actually, when we perform the dose initiation for the last case is gentamicin, when the patient is young and doesn't start before any type of antibiotic, and it is about to start gentamicin, meaning that the patient is young and about to start gentamicin. So for making those initiations in our practice, basically the doctors will start or will prescribe the gentamicin. Okay, by if I'm not mistaken, it will refer to the in-house reference book in the hospital. Okay, for example, on the previous case, the starting dose that the doctors prescribe for the patient is IV gentamicin 80 mg TDS. So from their perspective, that is the best that is the best starting dose for their patients if they want to start it with gentamicin. Okay, and but that is the practice that is usually observed in our Malaysian hospital. By right, we have to start the gentamicin after calculating the dose initiations. Okay, but if the patient is young and doesn't start any with antibiotic before, we can proceed with the dose initiation. And the information that we use to decide the dose initiation is by looking at the first population PK parameters. Okay, and it varies according to the drugs, not the patients. Okay, the basic PK of the drugs is varies according to the drugs. For example, if you want to know the volume or distribution of gentamicin, according to the established guideline or reference, it is between 0.25 to 0.3 liter per kg. That is population PK for gentamicin. But if your patients started with vancomycin, the VD for population PK is different from gentamicin, where for vancomycin, the VD, the population VD is 0.7 liter per kg. So that value of 0.7 liter per kg or the value of gentamicin of 0.25 to 0.2 liter per kg is already written in our reference guideline. And who decide that value is researchers. I think they have done the previous study research, and they have come out that for population PK of gentamicin and vancomycin, specifically for VD, it is written as 0.25 to 0.3 liter per kg for gentamicin and 0.7 liter per kg for vancomycin. Okay, so I hope that it answers question number two. And the last question, how is the relationship between other health professionals here in Malaysia? I think when we talk about the hospital or health clinic or any other setting from the tertiary level healthcare. We frequently see the role of doctors, or physicians, or specialists, nurses, physiotherapists, and also include the pharmacists or medical pharmacists. So since I've been here in Malaysia for about 30 years, I've been working with them in the hospital around 2 years before. I think our relationship is very a productive one, and we are respecting our role as doctors, as pharmacists. And if we look into the TDM services or clinical pharmacy services, we are trying to competing to each other, meaning that the doctor's role is to diagnose the patients and request for the TDM services, and then if they have one patient to be started with gentamicin, for example, so they pass back the role to clinical pharmacists in charge for TDM, and then we are doing our role to review the patients, whether that patient is suitable to be under TDM services or not, and then we have role from the pathology officer lab at the lab department, and then we can see the harmony relationship between different type of professional in Malaysia, between the doctors, the pharmacists, the lab staff, and also the nurses. There is no such thing that you are more powerful or no, we are more knowledge compared to this profession.
So the profession is equal in the hospital.
Yes.
Bagaimana, Sidki?
Oh,
Is it
yeah.
clear?
Thank you.
What's
Very,
your question?
yeah, it's very clear. But yeah, I think in my opinion, for Dr. 15 especially, I think it's very good to research or student exchange, not just for Bachelor of Pharmacy, also in I think in professional apotheker also, or a master degree also, to research exchange or student exchange. I think this
Mr.
yeah.
He wants to exchange students to another country.
Yeah.
Can. You can nominate your name and given to
Yeah.
the team, and the team will arrange for the step.
We try to
Yeah.
do the intrinsic exchange to UniKL, but in community pharmacy, but still the guidelines still ongoing.
Mr. Sirki is now pursuing masters or magister.
Yes,
ST.
master degree.
Master,
And,
yes, master.
and also you are currently working in the hospital, right?
Yes, I have experience for clinical pharmacies in hospital, but now I in master pharmacy, especially in science and technology pharmacy. I think, yeah.
Right. Okay.
Yeah.
I
Now
think
he
no,
do
all the
the
best to you.
research in Vietnam.
All right.
Yeah.
Very good. All the best to you, Mr. Sirki.
Thank you.
I think we
Okay,
have
thank
another
you.
question from Miss
Okay, the
Nelly.
next question, maybe Miss Nani, please.
Thank you. Is my voice clear?
Kurang keras suaranya.
Oh, yes. Okay. Hello, Mr. Safwan.
Waalaikumsalam. Ya, saya.
Introducing Nelly, a Master of Pharmacy student at Universiti. I have one question. Please allow me to ask about what are the actions that can be taken if the result of monitoring aminoglycoside drug levels are not in line with the therapeutic target. Okay, thank you.
Okay. Thank you for the questions by Miss Nelly. So if I can recap your question just now, is what are the action that must be taken when the therapeutic range of the gentamicin is not in line with the expected therapeutic range, right? Okay, so this is something that we commonly expect in our practice, where the dose given to the patient is not the dose given to the patients when we want to monitor the serum plasma concentration of the drugs, especially the pre and post level of gentamicin, is not within the range. So there are many factors which leads the patients doesn't achieve the expected pre or post level, pre and trough level, and post and peak level of gentamicins. Okay. So first, number one, we have to know your patient very well. If your patient is a neonates or healthy adult patients or special population patients. Okay. Number two is for you to know the conditions that your patient experience. For example, if me myself is a healthy adult individual, so I don't have any problem with my important organ, for example, heart, kidney, liver. But if your patient is not really is not really healthy person, meaning that your patient is having comorbidity of diabetes mellitus, hypertension, hyperlipidemia, and also your patients having organ damage, especially at the kidney and liver. So that will determine the outcome of the gentamicins in terms of their expected pre or trough level and post and peak level. Because as I mentioned before, that is considered as limitation and challenges in our TDM practice, where the patient itself is varied in the form of genetic polymorphism, the age, the organ performance, especially the kidney. Okay, so that is the factors which determine the expected whether the drugs, the serum plasma concentration of your drugs is in the within therapeutic range or not. Okay, meaning that that is important for you to know your patient very well, because let's say, for example, your patient is having renal impairment or chronic kidney disease. So meaning that their organs responsible for drug excretion or drug elimination is compromised, right? So on that time, you have to know that whatever you give to patients, whether you give drugs in the form of oral or intravenous, you have to make adjustment on that based on the patient's organ performance, especially the kidney. Then you have to look into the lab profile of the patients, identify the latest serum creatinine, and then you calculate the creatinine clearance. Then only you know your patient's kidney performance on that time. Okay, I think we are familiar with the classification of CKD patients, where it is stage 3, stage 1, 2, 3A, 3B, 4, and 5, according to the clearance. Right, Miss Lenny? We are familiar, right, with the CKD classifications? The stage 1 CKD, stage 2 CKD, the stage 3A and 3B CKD. So based on that classifications, we can know our patient very well, and we can proceed with the dose adjustments accordingly, according to the specific type of the drug that the patient administered. Okay, maybe vancomycin or gentamicins. So further action will be taken depending on the latest result of the serum plasma concentration of the patients, okay, and also the organ performance of your patients. I hope that it answered your questions, Miss Nelly.
Okay, thank you for your explanation. So clear.
Okay, there is still another question. You can say the question also in bahasa. Jadi boleh dalam bahasa Indonesia. Saya yakin Mr. Nur Safwan still masih bisa memahami pertanyaannya. Silakan. Miss Neni also our master students.
All right.
Baik, silakan. Mr. Nur Safwan, sambil menunggu, saya ingin bertanya tentang ini. Bagaimana cara kita memilih waktu sampling? How we choose the time sampling and how many samplings we used to do in one patient in 1 day.
Okay. For that question, Dr. 15, it is already clearly written in our pharmacy handbook, especially the clinical pharmacokinetics. For gentamicins, actually we can take a sample whether it is a pre-sample or post-sample or random sample. So for pre-sample, it's usually right before the dose or right before the next dose or 30 minutes before the dose. That is the pre-sample. basically for gentamicin. And for post-sample, it is 30 minutes after 30 minutes of completion of the infusion, meaning that 1 hour after those infusions, that is the time where we take the post-sample. And the third category of random sampling method is you can sample the patient, or you can take the sampling. You can take the sampling from the patients at any time of the 24 hourly. It depends on the first. It depends on the instruction from the doctors lah, whether they want to take pre or post or random sampling. Some of the drugs is okay for the random sampling method, and some of the drug is must be tailored according to the drugs. For gentamicins, we can actually take pre and take post sample 30 minutes before and 1 hour post infusions. For vancomycins, practically we can just monitor the post sample, the same also, the pre sample 30 minutes before. But I think we are moving towards monitoring the vancomycin towards using AUC over MIC. There is more precise in monitoring the vancomycins. Okay, provided that we take 2 samples in 1 day for vancomycins, then only we can perform the monitoring action using AUC over MIC.
So depends of the drugs, the
Yes,
characteristic
depend
of
on the
it.
drugs. Yes.
And we can do in before steady state or maybe after the steady state.
At least three and above half-life, because we assume that the drugs will reach steady state after a minimum 3 half-life. But basically, in theory, stated that your drug will reach steady state if there is about 3 to 5 half-life.
Yeah. Okay. So after they reach the steady state.
Yeah.
Thank you. I think there is one. Okay.
Yeah. I'm sorry, excuse me. I'm sorry, can I have question more again? I have very interest about your prototype smartwatch for monitoring gentamicin. I think not just gentamicin. I think all drug is not used is used. How to the mechanism your prototype smartwatch to monitoring level. This is some like spectrophotometry or different or how the mechanism to know about drug level in blood. Yeah, I think that's my question, Mr. Safwan.
The
It's very
research part.
interesting.
Correct. Okay. So actually, the prototype that we have successfully developed is sponsored under our internal grant in our faculty, which is sum up of 10,000 ringgit Malaysia. So that amount helps us in developing that prototype and proof of concept sensor. So basically, the fundamental concept of our sensor or biosensor is we are using a different type of engineering components. For example, we have OLED display and we have sensor that is specifically detect the wavelength of gentamicin once it's available in the patient's blood. Okay, but currently we are not sure whether the complex or the drugs identified by our sensor is really gentamicin or not. That's why I mentioned in the previous sharing sessions, we are now proceeding to the validating process at the clinical trial level, where we want to make sure that our prototype biosensor is specifically detecting complex of gentamicins, because gentamicins will form a complex with the blood in the patient's body. Okay, so if coming back to your question just now, actually our sensor, the input of developing the sensor is come from my collaborator at UniKL in Malaysia. So actually the resident is having engineering background. But we having the knowledge of clinical practice, the TM services, and the background knowledge of the drugs. So we provide all the information to the researcher at UniKL BMI, And based on that clinical knowledge informations, the researcher will try to develop in terms of what are the preferable sensors that we can use to detect gentamicin in the patient's blood, and what are the sensors that is can detect the specific wavelength of the gentamicins in the patient's blood. So that is the mechanic background of the sensor that we have developed at the moment. And we have been working to develop this sensor for about 2 years, starting from 2022, and now we are about to close the grant, and hopefully we can proceed to the next stage of validating the sensor that we have developed. Actually, that is not considered as a sensor yet. I mean, not considered as a product that we can use clinically in hospital or in the market, because that product is not enclosed in a proper type of box. As you can see, there's no wearable device that are enclosed. So that is only the proof of concept and proof of concept versions. So if we are able to transform the proof of concept into the proper prototype, it will be in the form of wearable device, like our smartwatch.
Yeah, it's very interesting. And yeah, it's very interesting to develop more again, and to the produce in smartwatch. I think it's very useful to outpatient, especially chronic patient. I think.
Yes.
Yeah.
Yes.
Congratulations. Okay.
All right. So if you have any more questions regarding these sharing sessions, Mr. Rizky, maybe we can have conversation after this. You can take my email or phone number from Dr. 15, and then we can discuss further.
Okay. Thank you. Thank you.
Sure.
Thank
Okay.
you.
Email and
All right.
Okay. I think we have one question more from Lutfi. Lutfi, boleh ditulis di chat kalau misalnya ini saya bacakan pertanyaannya. Sebentar. Saya dihapus pertanyaannya. Silakan Lutfi. Mbak Lutfi menuliskan di chat box. Bahasa Indonesia boleh, jadi biar nggak terlalu lama nanti ini. Oh ini, oke. So this is the question from Lutfi Anggraini, our magister student also. The question is, what are the challenges or obstacles that may be encouraged in implementing TDM for aminoglycoside drugs in clinical practice? The challenge, asking for the challenge.
All right. Thank you very much for the question given, Ms. Lutfi Anggraini. So I wish all the best for your Magister Pharmacy at UniKL. So your question is, what are the challenges or obstacles that may be encountered in implementing TDM for aminoglycoside drugs in a clinical practice? So from my experience, gentamicin is considered the most commonly used drug in our practice here in Malaysia, because the incidence and prevalence of infection due to gram-negative infections and some of the gram-positive infections is very high here in our clinical practice, and the drugs of gentamicin is frequently used in our practice. So number one is not all pharmacists having a good knowledge and understanding regarding the importance of performing TDM services in their unit or hospital. So because the Department of Pharmacy in Malaysia Hospital consists of the senior pharmacists and also the junior pharmacists who just graduated from pharmacy school or pharmacy university. So in terms of having knowledge regarding TDM, yes, they they are well equipped with the knowledge or basic knowledge of TDM during the undergrad, but since they are just junior pharmacists who just graduated from the pharmacy university or school of pharmacy, they are currently having very less experience in performing TDM services, including the calculation, etc. But if compared with the senior pharmacists, they are well trained, they are having a vast experience in TDM services. So if we look into these situations, comparison between junior pharmacists and senior pharmacists, there is a gap between them, where because our system here we have on-call pharmacists, whether it is active on-call or passive on-call. So during the on-call time, probably the number of TDM cases that has to be handled by the pharmacist is very high during the on-call time. So usually the on-call rotations is done by the junior pharmacist, and some of the rotation is also done by the senior pharmacist. So since they are having a very less knowledge within TDM services, so it is also can be considered as limitations or challenges, because how can you calculate the calculation appropriately when you have a very less experience, even though you have a good knowledge or basic concept of TDM knowledge from your university, but it is not something that we can ensure to practice a good TDM services during the practical at your on-call time. So that, I think, can be considered as one of the limitations or challenges if you want to make sure that the TDM of aminoglycoside drugs in our clinical practice. So I hope that answered your first questions. And your second question is there a difference in TDM monitoring of aminoglycosides in pediatric and geriatric patients? Yes, definitely we have a difference in TDM practice of aminoglycosides, whether it is gentamicin or amikacin, etc. For our patients, if they are kids patient or geriatric patients, okay? Because for PIDS patients, in order for us to decide the dose initiation or dose adjustment, we have to tally back with their body weight. And in Malaysia, clinical practice, if you want to decide the dose of each drug, we have to tell it in line with their body weight, okay? Body weight per kilogram dose. But for geriatrics, it is well established. We can use whatever value that we have in our reference or pharmacy handbook to decide the dose initiation for gentamicin especially. Okay, that is, I think, the general answer for question number 2. But if you look into more detail, the differences in TDM monitoring of aminoglycoside in PIDS and geriatric, I think if you want to know more detail, the differences between these two populations of PIDS or even neonates and geriatric or adult patients, we have to look into their basic pharmacokinetic parameters regarding their half-life, their clearance, elimination rate constant, the VD. So that's determine the differences between TDM practice of towards PIDS patient or neonates and the TDM practice towards geriatric or adult patients. Okay, I'm not sure what are the type of clinical pharmacokinetics handbook that you are currently used in Indonesian hospital, but we in the Malaysian setting, we have our established guideline to practice TDM services for clinical pharmacokinetics that was published by the Pharmacy Service Division's Ministry of Health, Malaysia. Is that answer your questions, Ms. Lutfi?
Ms. Lutfi, sudah menjawab pertanyaannya? Oke, sudah. Thank you for the answer.
All right. You're most welcome.
Ms. Lutfi's work in hospital, but in her hospital there is no TDM, even for aminoglycoside.
All right.
Okay. So Indonesia sometimes is about the biaya, because it's very expensive, right? Okay. I think there is no question more. Mr. Nur Safwan is very exciting lecture for this morning for my students in undergraduate student and also our master student. We also say very thank you for you to giving us the information of the introduction and also the case study of about the TDM in Malaysia. So our student can get the information or get the practice about this, because in our lecturer we usually just give them the theory, not the practical, because most of our lecturer not work in hospital, so we don't do the practice in hospital. So it's our limitation in Faculty of Pharmacy, University of Jember. Before we closing this guest lecture, I would like to give you the certificate as a guest lecturer. Mungkin Mas Kusairi bisa di share sertifikatnya, nanti saya akan sampaikan juga lewat email ke.
Boleh.
So we can take a picture. This is our certificate for you as a speaker for today guest lecture, Mr. Nur Safwan. Thank you so much. And before we closing this Zoom, we will take a picture together. Maybe for all the participants, you can open the camera and we will take a picture. Mas Kusairi bisa dipandu ya.
Siap.
Open the camera. Dibuka dulu kameranya sebentar saja. Bisa dihitung?
Ready, page 1. 1, 2, 3, 4. Okay, next. Page
Saya
2.
buka kamera. Kejap ya.
It's on cam. 1, 2, 3, 4. Page 3. 1, 2, 3, 4. And last page 4. 1, 2, 3. Okay, thank you, everybody.
Thank you, Mas Kus. Sebentar for the link presentation. Wait. All the participants can fill the form for the presentation and also the certificate. And once again, thank you to Mr. Nur Safwan for your coming today. Hopefully we can see each other in Malaysia or maybe in Indonesia again for the next.
Again.
And maybe for the next, we have our student goes to UniKL.
Alright, that's good. Boleh sampaikan salamnya kepada ni ya, Pak Nuri, Pak Amrul semuanya.
Oh iya, siap. Sampaikan juga salam kepada Padekan Prof. Fuad.
Boleh.
Baik, terima kasih. We close this guest lecture. Thank you so much for everyone and have a good day. Assalamualaikum warahmatullahi wabarakatuh.